Hello guys, NEET PG 2025 is finally over and you guys can have that well-deserved vacation you always wanted to take. And I really hope you have relaxed for a couple of days. And I had asked few of my juniors about the questions which are asked in NEET PG 2025, and what they said is it was relatively easy, but in some questions the options were a bit confusing. They were stuck between the two options and they ended up making silly mistakes. So let me help you decode why did they make those silly mistakes and make sure you don't repeat such mistakes in NEET PG 2026. You know what mistake you guys do? You just go through the previous year questions, not the concept. You just go through the questions, you memorize the question and enter the exam hall. And when you encounter a similar looking question in the exam hall, your brain automatically tells you, yeah, this was the question you had solved, so this is going to be the answer, and you skip reading the entire question, or you immediately go choose the answer which you thought was the right because you have already solved a similar question. So this is where most of you will go wrong and your rank falls drastically. So I want you to focus more on the concept of the question and not the question itself. So through this video, I'm going to teach you how to approach a previous year question and not make that silly mistake again in the next year. Because the topics on which the questions come are going to be same. So just the way of asking the questions or the way of framing the questions is going to be different. So don't just focus on the previous year questions, focus on what concept is the examiner testing you on. Now let's decode the surgery questions and topics which were asked in NEET PG 2025. So let's go. Every year there's a question on Strasberg classification, but the examiner may just ask it in a different way. He may just give you an image and ask you what is the type, or he may ask you a kind of question like this. During cholecystectomy, the surgeon notices brisk bile flow from a partially cut common hepatic duct. Which Strasberg type is this? So you may have just looked at the image. By looking at a sentence kind of question, you may get confused. Which was partially cut common hepatic duct? Was it A? Was it E1? Was it E2? Now everything feels similar to you because what you had practiced for during the last previous year MCQ was there was an image given and he asked you what Strasberg type was this. So your brain got fixed to that key. Next year also an image can be asked, but this time your brain got confused. So let me clear that confusion for you and teach you what the Strasberg classification exactly is. Okay, so this is your gallbladder, this is your bile duct, this is your right hepatic duct, this is your left hepatic duct, which joins the cystic duct to form the CBD. Now what happens during cholecystectomy is you clip the cystic duct and you cut it and you do the cholecystectomy. So the clip remains here in a normal case, but sometimes what may happen, the clip may fall off. So there's going to be bile leak from the cystic duct stump. So this is your Strasberg type A. Leak from the cystic duct stump is your Strasberg type A. Now what about type B? Let's suppose this is your biliary tree, and normally there's a branch which joins the right hepatic duct. It's called the right posterior sectoral duct. In a normal case, it joins the right hepatic duct. But what happens sometimes, this right posterior sectoral duct will have an aberrant route, and instead of joining the right hepatic duct, run posteriorly behind the cystic duct and then join the common hepatic duct. So this is aberrant right sectoral duct. There are 4 types in this aberrant sectoral duct which you don't need, it is SS level question, but what you need to know is just this, that the normal right sectoral duct joins the right hepatic duct. In case of an anomaly, this joins either the common hepatic duct or the common bile duct. And in such case, while doing cholecystectomy, you might accidentally clip this aberrant right sectoral duct, and while doing cholecystectomy, you may also cut this duct. So what happens if when you have clipped this, accidentally you clip the right sectoral duct as well? So this is your Strasberg type B, that is occlusion of the aberrant right sectoral duct, or B for block of the right sectoral duct. And if there's no block, If the clip falls off and there's a bile leak from the aberrant right sectoral duct, then it's your type C. Type C is leak from the aberrant right sectoral duct. What is D? D is when there is lateral injury to the common hepatic duct. And what about E? E is when there is complete transection. This is your cystic duct and this is your aberrant right hepatic duct. E1 is when there is complete transection. This is more than 2 centimeter from the confluence. If it is less than 2 centimeter confluence, then it's E2. What is E3? E3 is when there is injury at the confluence, but both right and left are still connected. It would be E4 if this E3, sorry, and it would be E4 if the injury separates both the right and left hepatic duct, and it's E5 if there's injury to both aberrant right sectoral duct and the main duct. So hope you won't forget Strasberg classification next time you have a question on it. So now coming to the question which was asked. Surgeon notices brisk bile flow from a partially cut common hepatic duct. You've seen in the classification what was partially cut common hepatic duct, that was D, right? So the answer is option B, that is type D. So I want you to master each and every topic which was asked in the previous question and not just mug up the MCQ or not just solve the MCQ. I want you to retain the concept what was asked in the previous year question. Now to the next concept. A patient with a stab injury to the wound is hypotensive. BP is 70 by 40. He has tachycardia and with distension. He is asking you the next best step. So what does he wants to know? He wants to know whether you know what the management protocol in a patient of stab injury. The next time he may entirely change the question. He may say a patient with stab injury, the patient is completely stable, but you can see the omentum hanging from the stab site. What's your next move? Or he may say the patient is completely stable. There is stab injury, but there is no peritoneal breach. What's your next? So you need to master the concept if you want to answer question on the similar topic. So what is this concept of stab injury? Let me tell you in brief. See, if a patient comes to stab, you need to first check is he hemodynamically stable or unstable. If he is unstable, then the next step is laparotomy. No investigation, nothing. If he is unstable in a patient of stab injury, immediately take him to OT and do exploratory laparotomy. But the scenario changes when he is hemodynamically stable. If he is stable, you need to examine the penetration site. Is there a peritoneal breach? If yes, or there is no peritoneal breach. If there is peritoneal breach, then again, no matter if he is hemodynamically stable or unstable, you have to take him to laparotomy. And if there is no peritoneal breach, you can observe him. So this is the management protocol of a stab injury in brief. So if the patient is hemodynamically stable, you can subject him to USG fast and CT angio as well. But the general concept is this: if he is unstable, take him to OT. If there is peritoneal breach, take him to OT. But if there is no peritoneal breach and if he is stable, only then you'll observe. So here, what does the examiner want to know from you? Stab wound and is hemodynamically unstable. So immediately you're going to take him to laparotomy. Now let me tweak the question a little bit. Let's say there is stab wound to the abdomen, patient is stable. What is the next best step? Now, in the given option, the next best step would be a USG fast. If there was an option of local wound exploration, then that would be the best option. But since USG fast is in the option, that becomes the best answer. So you need to not only look at the question, but look at the options as well. Sometimes the options may not be ideal or the question may not be ideal, but you need to choose the best answer from the given option in the question. So that's the skill you need to develop during the upcoming days if you really want to ace NEET PG 2026. Now take a look at this question. This is a question which has integrated radiology along with surgery. Barium swallow is given and you need to diagnose that, and then you need to answer the best investigation of choice for that condition. He may ask you what is the diagnosis, or he may ask you which of the following statements is wrong and give you 4 statements. So There's a lot of possibilities he can ask you on these type of questions. So the concept is what you need to focus on. So let's see, what does the barium swallow show us? The bird beak appearance, right, which is seen in achalasia cardia. And you know the investigation of choice in achalasia cardia is high resolution manometry. Now to the next question. A 65-year-old woman presents with painless progressive jaundice for 3 weeks and dull right upper quadrant pain. She has a long-standing history of gallstones and on examination, no palpable gallbladder, and there's mild hepatomegaly. What's the most likely diagnosis? See, previously you might have seen this question where there is a painless progressive jaundice and the answer was carcinoma head of pancreas. On multiple occasions, you might have solved this question. And as soon as you see painless progressive jaundice in the question, you straight away jump and mark option A, carcinoma head of pancreas. But you miss an important keyword here. There is no palpable gallbladder. And you got a crucial MCQ wrong, because in this question, the answer was carcinoma gallbladder. Now, why did this happen? Because subconsciously you're preparing just for the question. You're not preparing the concept. Bear in mind, you are just going through the question and not the concept. This is the biggest mistake you guys are doing. How can I say you guys are doing the mistake? Because I was the same. I have done these mistakes too. And these mistakes have cost me my INICET rank. Because during the mock exams, I used to be in top 20, top 30. But when I gave my INICET, my rank was 800. Quite shocking actually. But what mistake happened was during the mock exams, the questions were repeated. They're the exact questions from the Q bank. So I knew I have solved these questions and this is the answer. But what happened in INICET, the concept was same, the question remained the same, but he just tweaked the last line or he just interchanged the options. So my brain got confused because I was practicing MCQs just by looking at the MCQs itself and not the concept. So I changed my strategy. I focused on the concept, and during my next exam, that is NEET PG 2021, I did it. I secured a rank of 135, where my previous NEET PG 2020 rank was 1.22 lakh. You need to focus on the concept and not just blindly solving the MCQ and keeping the MCQ in the back of your mind. And through this question, the examiner wants to know whether you know the differential diagnosis of painless progressive jaundice. Now, when does painless progressive jaundice happen? This is your gallbladder. This CBD is going to join the pancreatic duct, main pancreatic duct, along with your pancreas. So, this is your pancreatic duct, which opens the ampulla of Vater, and your common hepatic duct joins the ampulla of Vater, and the bile is drained into the intestine. So, you will have obstructive jaundice when there is something obstructing the bile flow into the CBD. So it can be anything from the junction where cystic duct joins or where it enters the ampulla of Vater. So it can be a stone, it can be a malignancy blocking the ampulla of Vater, or it can be cancer of the duodenum. It can be a CBD stone. But what is he asking? He's asking you painless progressive jaundice, and if it's a stone, patient is gonna have painful jaundice. So the stone is not an option. Choledocholitis is out of the question. Now there are three options, right? So if it's a case of head of pancreas, let's suppose there is growth in the head of the pancreas which is blocking the bile flow. So what happens now? There is obstruction to bile flow, and the bile keeps on collecting to the entire biliary tree, and there is biliary tree dilatation. So you're gonna have distended gallbladder, distended CBD, and the distended intrahepatic biliary tree as well. But look at the question, there is no palpable gallbladder. Gallbladder is not palpable. So, see, head of pancreas is also out of the question. There's another history in the question. The patient has long-standing history of gallstones. So now what happens when there is long-standing gallstones? When there are gallstones, the GB is going to be shrunk. In case of chronic cholelithiasis, the gallbladder is going to be shrunk. And you know, chronic cholelithiasis is a risk for CAGB? So here the answer was carcinoma gallbladder and not C-head of pancreas. And now you have gallbladder mass which has obstructed the biliary fluid and which has caused painless progressive jaundice. But since the patient has chronic cholelithiasis, the gallbladder is shrunk, so you are not able to palpate the gallbladder. I really hope you have got some insights on painless progressive jaundice and the differential diagnosis behind it. Next question is on CEAP classification of varicose veins, and every year there is a question on varicose veins, but the concept may be different. Sometimes he may want to know about CEAP classification. The next time he'll want to know about investigations. He may ask you the management. So you need to know varicose veins in detail. And this time there's a little bit of confusing question on the CEAP classification, because in this question there are two options he wants to know. There is skin pigmentation also. There's a healed ulcer also. So what is skin pigmentation is C4A and healed ulcer is C5. Now remember, always priority will always be the higher class. So in this, the answer is C5 and not C4B or C4A. C4A is not even in the answer, so that's out of the question. But if he gives you, and the question has C4A, let's suppose this is C4A, you will be in a little bit of confusion. So which one to choose? So it's always the higher number which takes priority than the lower one. Now, what is the CEAP classification? C is the clinical classification, E is the etiological, A is the anatomical, and P is the pathological classification. There are C1, 2, 3, 4, 5, and 6. What is 1? 1 is telangiectasia. C2 is varicose. C3 is edema. C4 is A, B, and C. A is skin discoloration. B is lipodermatosclerosis. And C is coronaphlebectasia. C5 is a healed ulcer. And C6 is an active ulcer. There is C6R as well, that is recurrent active ulcer. E is the etiology. It may either be primary or congenital. A is anatomical, that is superficial, deep, or perforators incompetence. And P is the pathology behind it. It may either be obstruction or reflux. Coming to the next question. A 30-year-old woman, incidental liver lesion with central stellate scar. The moment you see this, you jump to mark the answer as focal nodular hyperplasia, because you have solved this question multiple times, and if you see central stellate scar in the question, you jump to mark FNH as an answer. But this was right, luckily. But what if I change the question a little bit? A 25-year-old man presents with vague abdominal discomfort for 2 months. No history of liver disease, alcohol use, or hepatitis. MRI shows a well-defined mass in the left lobe with a central stellate scar. If this was the question in your exam, you see a central stellate scar, again you would have jumped and marked the answer as focal nodular hyperplasia even without reading the question completely, and miss upon some important points which was given. There's a heterogeneous enhancement and ALP level is elevated. These two statements change the answer completely, because the answer now becomes fibrolamellar variant of HCC. Even this has a central stellate scar, but in fibrolamellar HCC, the ALP level is elevated and there is heterogeneous enhancement in the arterial phase of CECT. So be really careful what the examiner wants to test you on, not just look at central stellate scar and blindly mark focal nodular hyperplasia the next time. Okay, now for a simple question. On post-op day 2, after total thyroidectomy, patient develops tingling around the mouth and carpopedal spasm. This is a direct question, you either know or don't know. This is a case of hypoparathyroidism when the patient has symptoms of hypocalcemia. So these are the kind of questions you cannot afford to miss, because these kind of questions, almost 99% of them would have gotten correct. And by any chance, if you got nervous or whatever the reason may be, you got this question wrong, your rank is going to fall in thousands. And since this time the exam was comparatively and relatively easy, if you have gotten these kind of simple MCQs wrong, your rank is going to drop down by thousands just because of a single wrong MCQ. So the next time, be really careful and make sure you have a calm mindset during the exam. So now, a question on CA breast, most important topic, and every year you have a question on CA breast, whether it may be staging, it may be management. You have to be perfect when it comes to carcinoma breast. So in this question, a 50-year-old woman presents with rapid onset swelling, redness, and warmth of the left breast. Skin changes cover more than 1/3 of the breast surface and there's no distant metastasis. So what is the T stage? Now the moment you see rapid onset redness, warmth, and more than 1/3 breast surface coverage, you go and mark the answer as T4D, which is absolutely correct. And you will have this scenario in the back of your mind, and the next time what he does, The examiner is going to change a little bit. Skin changes localized to less than 1/3 of the breast, and there was no redness and no warmth. 50-year-old woman presents with rapid onset swelling on the left breast with skin changes which is localized to less than 1/3 of the breast surface with no metastasis. Now the stage is going to change to T4B and not T4D because localized skin changes like pudiorange or ulceration is T4B. Now let me make the T stage very simple for you. So let's suppose this is your chest wall, this is your pectoralis major, and this is your pectoralis minor. Then you have breast tissue with the breast lobules over this. So now let me give you an example of 4 tumors. The first tumor 1 into 1 centimeter, the second is 3 into 4 centimeter, the third one is 5 into 5 centimeters, and the fourth tumor is 7 into 6 centimeter. What T stage does each of these tumors constitute to? Let me explain you that. So T1 is any tumor less than 2 centimeter. T2 is a tumor in between 2 to 5 centimeter, and T3 is a tumor which is more than 5 centimeter. And T4 has 4 subdivisions, that is A, B, C, D. A is the involvement of chest wall, B is the involvement of skin, C is both A plus B, and D is inflammatory carcinoma of the breast. So now, according to the diagram, this one is T1 since it's less than 2 centimeter. This tumor is T2. This tumor will be T3 and this one will be T4. But look at this. This tumor has invaded pectoralis major. So is it T4A? No. See, the chest wall does not include pectoralis major and minor. The pectoral muscles are involved. It's not T4A, it will be T3. And similarly, if you see nipple retraction or dimpling, it doesn't mean it's T4B, it's still T3. So T4A is only when intercostal muscles or serratus muscle is involved. And T4B is when you have pudiorange, ulceration or satellite nodules. T4D is when you have rapid onset skin changes and it must involve more than 1/3 of the breast. So be very careful what the examiner wants to test you. So the next time the examiner might change the question like a 50-year-old woman presented with 3 into 4 centimeter lump with nipple retraction and pectoralis major involvement. What is the stage? Now, if you're not careful, you see nipple retraction and pectoralis major involvement, and you may mark T4C. But nipple retraction does not mean skin involvement, and pectoralis major does not mean chest wall involvement. And since the tumor is 3 into 4 centimeter, T stage would be T2. So be very careful what the examiner is asking you, and don't fall for the trick. So the next one is a direct question. Patient with thyroid nodule has high calcitonin level, likely diagnosis. Answer would be medullary carcinoma. So the next time he may change the question like this. A patient with a thyroid nodule has high calcitonin levels along with hypertension, diarrhea and kidney stone. What is the diagnosis? When you see the high calcitonin levels, you directly jump to medullary carcinoma. But really miss these 3 important keywords, which is hypertension, diarrhea and increased kidney stones. That is, patient also has pheochromocytoma and increased calcium due to parathyroid adenoma. So along with medullary thyroid cancer, this is meant to A. So you may fall for this trick the next time. Just by looking at the high calcitonin level, you may directly jump to medullary carcinoma, but really miss these important keywords which were pointing out to pheochromocytoma and parathyroid adenoma, and the diagnosis was meant to A. Or he may confuse you even more with a question like this. A patient with thyroid nodule has high calcitonin levels. Patient is tall, has long limbs, oral mucosal nodules, hypertension and diarrhea. And he gives both MEN 2A and 2B as option along with medullary carcinoma of thyroid. Now you are confused which was it MEN 2A or 2B. Here the patient has features of Marfan syndrome. He has mucosal neuromas along with pheochromocytoma. So this condition is meant to be. Keep practicing multiple MCQs. Make sure your concepts are really strong. That will help you improve your MCQ solving skills and not just mugging up the topics and blindly solve going for the MCQ. So now, which of the following is false regarding Vicryl Plus? It is braided and absorbable. It is coated with triclosan for antimicrobial activity. It is monofilament suture. It is commonly used for soft tissue approximation but not for CVS or neurological tissue. Now, to answer this question, you need to have little bit of knowledge about the sutures. See, sutures can be either absorbable or non-absorbable, and in both they are either monofilament or braided. Now, what is a monofilament absorbable suture? That is called monocryl, and if it's braided, it is vicryl or vicryl plus or rapid. Even your PDS is a monofilament absorbable suture. Now, which are the non-absorbable sutures? If it's braided, that is your silk and your nylon and proline are non-absorbable monofilament sutures. So now the question was of vicryl. Is it braided and absorbable? Yes. Is it coated with triclosan? Yeah. The image itself tells you it is coated with triclosan. It is a monofilament suture that remains for the body more than 6 months. No. Monofilament is a monocryl suture and not vicryl, and it is commonly used for tissue approximation but and not for cardiovascular and neurovascular tissues. For cardiovascular and neurovascular, you mostly use proline sutures. So the answer here was C. Make sure you are very attentive during your internship and learn as much as possible about these sutures. So that's it for today. I hope this video really helped you in understanding the concept behind solving MCQs. And please mention in the comments if you want me to create more such videos on MCQ solving, and also mention what topics do you want me to create. Share this video to your fellow NEET PG aspirant, and also subscribe because a lot of informative videos are on its way.